Very good afternoon, everyone. I'm Dr. Priya. Today we are going to discuss our vein of Galen malformation. Basically, vein of Galen malformation is a atriovenous fistula or an abnormal atriovenous lesion. So what happens? There is abnormal direct communication within the arteries, which has very high blood flow, and they drain directly into a vein. And the vein that accepts this flow, like this high pressure flow, normally should disappear around 11 weeks of gestation. But and it will be known as vein of Galen. But what happens in vein of Galen malformation? This vein that receives it high arterial flow grows and balloons out and persists inside the fetal brain, and it leads to a lot of complication. It is usually diagnosed in early pregnancy, in late pregnancy, around third trimester of pregnancy with an antenatal ultrasound. Sometimes it's diagnosed in the neonatal period when the babies are presenting with engorged facial veins, and some babies may develop seizures, hydrocephalus, and sometimes they present late in childhood where they present with persistent headaches and seizures. Today we are going to review a case which we recently saw. We'll understand the anatomy and pathophysiology of vein Galen malformation. We'll recognize the pre-diagnostic imaging modalities and prenatal findings. We'll discuss the management strategies, and we'll review the neonatal management and any kind of management that is offered. So this is a lovely 25-year-old woman, G3P0, which presented at 30 plus 6 weeks of pregnancy to our high-risk clinic with an ultrasound showing a growth lag in one of our twin B. And it was a DCTA pregnancy. Patient was otherwise healthy, was not taking any chronic medications, just taking her prenatal vitamins and supplements. The family history was non-contributory. There was no history of congenital anomalies, developmental delay, or recurrent pregnancy loss. And this was her pregnancy, very straightforward, no complications so far, normal anatomy scan, normal NT scan, NIPT was repeated twice, it was no call results, and we offered genetic counseling, but she declined any kind of invasive testing. We did a growth scan at 25 plus 1 gestation, which showed a selective IUGR, and then she was followed up with the third trimester ultrasound at 30 weeks, which showed a fetal biometry, the twin A measuring 13 centile, twin B 16 centile, normal A5 and doctors. But we found an unexpected finding, like a twin B showed a large intracranial vascular mass, which is located posterior to the thalami, which showed high velocity arterial flow, and there was no ventriculomegaly, no abnormal brain maturation, and no signs of cardiac failure like pericardial diffusion, ascites, polyhydramnios. The appearance of ventricular mass was described consistent with vein of Galen, and we offered further diagnostic testing in terms of fetal MRI. Patient was properly counseled, and the prognosis was explained as the volume was 1361, so which is a very favorable range, and the baby didn't have any signs and symptoms of heart failure and any other neurological damage. The next we booked an ultrasound in 2 weeks to assess the fetal cardiac condition. Fetal MRI was offered and was transferred to our high-risk clinic for management and talking about delivery options. So coming to vein of Galen malformation, it is a very rare atriovenous malformation in the fetal brain, which involves the median prosencephalic vein of Marcos. Vein of Galen malformation is associated or may be isolated. If it is associated with cardiac abnormalities, cystic hyperoma, and other CNS lesions. It is very, very rare, occurs in 1 in 25,000 live births and contributes to 1% of intracranial vascular abnormalities. But if you come to pediatric age group, it represents around 30% of vascular malformation. And as we discussed, it develops very early in the gestation, like 6 to 11 weeks, due to abnormal development of median vein. And talking about embryology, these are my 3 pictures. The first picture, you can see there's a big vein in the dorsum of the fetal brain. And this vein is known as median prosencephalic vein. And during late so this develops around 6 to 8 weeks of pregnancy. So around 11 weeks of pregnancy, the agitated part becomes fenestrated and becomes lacy like, and it kind of disappears. Whereas the posterior part of this vein, it persists and it is known as vein of Galen. When there is a malformation happening, when there's a vein of Galen malformation happens, there is a atriovenous fistula which develops at this site, and it becomes a very high flow fistula, and it kind of leads to very backward pressure, and there is will be dilatation of the median prosencephalic vein, and then the backward flow goes into the straight sinus and the superior sagittal sinus. So these all become a very high capacitance and high flow system. So median prosencephalic veins, which basically drains the shunt, it lacks any fibrous wall and is very unsupported, lies inside the subarachnoid space, and therefore balloons out into a larger size. And there will be hemodynamic consequences because of presence of this IV fistula. Because of this ballooning out of this vein, it puts a lot of mass effect and pressure on the brain tissue, and there will be development of hydrocephalus due to improper venous drainage, and mass effect leads to brain ischemia, and sometimes it ruptures and leads to subarachnoid hemorrhage. There will be high cardiac output failure because this AV fistula develops a short circuit with the heart. So blood quickly goes from the heart to meet the increasing demand of this AV fistula and comes back at the cost of not supplying other organs. So there will be always a risk of high output cardiac failure and cardiomegaly in these babies. If you see this picture, the first picture shows what happens in utero when the baby is still inside mom's uterus, and the second shows when the baby is born. So placenta offers a low resistance circulation and it prevents the high flow, the intracranial shunt. But when the baby is born and the placenta is gone, there is cessation of placental supply, and the placental flow suddenly stops and increase the forward to this intracranial shunt. And as you can see, this is a very high flow of blood that goes from the shunt to the heart and back and forth. There will be development of pulmonary hypertension, and there will be signs and symptoms of right heart failure. And the flow across the foramen ovale and the ductus adjacens disperses. Usually, it is seen 80% of the left ventricular output is supplied to the brain in severe, I mean, extreme of cases. And this necessitates a compensatory increase in cardiac outflow and volume to maintain this perfusion. So this high output cardiac thing leads to high ventricular intracavitary pressure, and it leads to decrease in subendocardial flow and promoting myocardial ischemia. So babies are at risk of myocardial ischemia. And neurological manifestations are basically because of cerebral venous hypertension, and increase in cerebral venous pressure leads to resorption of fluid, leading in hydrocephalus, cerebral edema, and hypoxia, and results in progressive cerebral parenchymal damage. So babies will have delayed milestones, will have many neurological sequelae because of that. And we already discussed the presentation can vary in infants, neonates, and children. Infants usually presents with macrocephaly, hydrocephalus, and delayed milestones, but in the neonatal period, when they are born, they present with cardiac out failure and cyanosis. And late in adult children, when they are a child, they usually present with persistent headaches and seizures. So it's very challenging to diagnose a vein of Galen malformation. Unfortunately, we can able to detect in third trimester. And the dilated median prosencephalic vein appears as an anechoic midline structure posteriorly. And when we put Doppler into it, it shows a luxuriant LH flow. And there might be signs of heart failure like polyhydramnios, hydrocephalus, and cardiomegaly. We usually offer the fetal MRI as the next stage of investigation because it is very important to characterize the anatomy of surrounding structures and also assess the brain parenchymal damage and hydrocephalus. These prognostic factors are not very evidence-based, but however, we kind of hang around these prognostic factors to offer counseling. Poor outcome is known if there are major brain lesions, tricuspid regurgitation, and if the VOGM volume is more than 20. And this slide is a representation of the fetal brain, which is very, very normal. And the first slide, you can see the fetal cerebral vasculature, which shows an anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery. The mid is the MRI, which shows a normal fetal brain that has no ischemia, there is no dilated veins anywhere. And the third is the cerebral venous sinuses. Usually the vein of Galen malformation happens here, so that it puts a lot of backward pressure to the straight sinus, which becomes dilated, and then pressure to the transverse sinus and sigmoid sinus. So this is the ultrasound we did for this patient. In the first ultrasound, you can see there is a midline and echoic fluid filled structure, which is a cyst, of course. And when we put Doppler, you can see shines like a light bulb. There is a very increased flow on this cyst area. And the third picture shows the venous blood flow, which is the low resistance blood flow, and the fourth picture shows the arterial flow, which is the high resistance flow. Coming to the fetal MRI, you can see the dilated median venous pouch, which is basically the median prosencephalic vein of Markowski with the AV fistula. And the second is a tubular structure. The vein kind of drains into the structure, and it is known as the straight sinus, which is distended. And then the straight sinus goes back and drains blood into the occipital and the kind of transverse sigmoid sinuses, and these are also dilated. However, there is no brain injury on MRI, and there is no ischemia that is detected on MRI. This is an ultrasound which shows basically on grayscale ultrasound, if we see there's an anechoic midline dilated cyst-like structure, which is seen on grayscale. And when we put color Doppler onto it and change our direction of the flow, we can see there is LH color flow. Very luxuriant, can never be missed, and it shines like a bulb. And this tubular structure is a straight, and this is the transverse sinus. So there is increased flow inside the straight and the transverse sinuses as well. So basically, it is the AV fistula, as we discussed. And coming to the differential diagnosis, the first differential diagnosis can be an arachnoid cyst, which is a fluid-filled cyst in the mid part of the brain. But when we put Doppler into it, there is no flow across it. And second is a choroid plexus cyst, the same thing, there is no flow, it's just an anechoic fluid-filled cavity. And the third is a Dandy-Walker malformation. So Dandy-Walker malformation is basically a posterior fossa malformation where there is absent of cerebellar awareness and the fourth ventricle is dilated and there is no flow in there. Coming to the genetic consideration, we should offer this patient genetic counseling and testing. Usually, geneticists offer VES to these patients to test for variants of call4 or other genetic mutations. And coming to fetal management, we need to do basically ultrasound to monitor fetal cardiac issues and development of hydrops. We have to arrange a fetal echocardiography to assess the heart strain. Right now, usually no in utero options are available, right? But there are few trials that are going in the States where they look for early fetal intervention. If there is signs that this AV malformation is increasing in size, or the flow, like it's kind of putting a lot of pressure on the fetal brain and causing brain ischemia, and there is a risk of heart failure. So what they do, they they go through the uterus, they put a needle inside the uterus, they go through the sinus, the pulsine sinus, and they kind of decrease the high flow and bring it to low flow so that the pressure will be relieved and the prognosis will be better when these babies are born. So a timing, we have to decide the timing based on whether the baby is going to develop complications or not. Delivery should be offered in a tertiary and quaternary medical center with immediate NICU availability and access to neurosurgeons and pediatric cardiologists. We usually offer them vaginal birth, but cesarean section, of course, going to be indicated if there is an obstetric indication. Postnatally, certain investigations are done like MRI, MRI angiography to detail the vascular mapping. Embolization is the mainstay of treatment, which is done by the neurosurgeons and neurointervention radiologists and performed in all stages. The timing of intervention really depends whether the child is sick or not, and also depends on presence of symptoms like presence of high output cardiac failure, presence of any brain injury. And prognosis will depend on a lot of factors like presence of heart failure, hydrocephalus, ischemic brain changes, and patients should be thoroughly counseled that the survivors may have developmental delays or neurological deficits. In extreme of cases, when there is a hydrops happening, there is a risk of intrauterine demise, high morbidity and mortality if we don't treat. So early intervention is the key, and ongoing risk of neurodevelopmental issues will be always there in terms of seizures, persistent headaches, motor delays. So coming to the summary, VOGM or a vein malformation is a complex malformation which requires a multidisciplinary approach. As we did know, early detection and close monitoring is the key. And postnatal intervention, especially embolization, are offered to improve survival. But neurodevelopmental follow is very, very essential. Thank you, and free feel to ask any question.